Welcome to Cardiac Arrest Beyond the ACLS. You know, that rhymes. I actually didn't notice that rhymes until right now. In this video, we're going to talk about what exactly is high quality CPR, right? High quality compressions. We're going to also look at doing all the things and the patient live. Psych, they don't. What else can we be doing to improve that chances of that patient survival? So stay tuned. Let's get this video started. My name is Leaton and welcome to the video. I understand you're on your journey here to become a paramedic, which is amazing. I don't know why you chose to give up sleep, but kudos to you. In this video, man, we're going to try to get everyone comfortable with the idea of running a cardiac arrest. There is a protocol set in place, which makes things a little bit less chaotic. Still chaotic, but less of a decision processing or less mental effort on the provider. So what I mean by this is that if someone is dying in front of you, right, they're in the back of your truck and they just start dropping, right, they're about to crash, they're about to die, it becomes a little bit chaotic, right? It becomes very stressful. You got to try to stop them from dying. You got to figure out what's going on and how you can reverse it. However, in cardiac arrest, that ship has already sailed. They're on the ground and they're not breathing, they're not responding, their heart's not beating. You know exactly what needs to be done. You need to maintain those body systems because they're not doing it on their own, right? The heart's not pumping and they are not breathing. So you got to take over breathing for that patient and pumping that heart. So you initialize CPR, you start your chest compressions, and you fix the airway, right? You bag them if you got to bag them. You do all the things and then you hope it works. That is basically it. You do all the things and you hope it works. That's it. So in a cardiac arrest situation, the normal ACLS protocol is going to tell you first thing you got to do is you're going to get on that chest, start doing chest compressions. Now I'm skipping over a few things, right? If someone goes down and you notice they're not moving, you're not going to immediately run over there and start squeezing on their chest, right? You do want to check for a pulse and make sure this actually is a cardiac arrest, right? Someone didn't just like pass out and then, you're doing more harm than you are doing any good, right? So you will evaluate, check for pulse, check for responsiveness, and then you activate, your 911, you activate emergency response, and you signify for someone to, get an AV or whatever the case is. Now, just so you are aware, you're not going to say somebody call 911 or somebody grabbing an AED. It's also very important that you take command of that scene when it happens, okay? So you will specifically call someone out, even if you got to point at them or say you in the red shirt. You would specifically tell someone call 911 if you're not doing so yourself, and someone to go get that AED as well. Because everyone is going to assume that someone else is doing it if you just say somebody call 911 or somebody grab an AED, okay? So that's very important to know. Once you've initialized those steps, and yes, this patient is not breathing, you've checked the pulse, you've tried to stimulate them, you've tried to get a response, nothing, awesome. I mean, not good for them, but at that point you start chest compressions, right? For compressions, you want to be doing a rate of 100 to 120. Make sure you're having good depth and giving that chest time to recoil back to its normal alignment position. That way you're having good preload of the heart as well. So your form does matter. Make sure you're locking your hands, keeping your elbows straight, and just use that upper body to compress. You want to push hard, you want to push fast, and that will give you the best quality compression that you can possibly achieve. When we talk about early defibrillation, right, there's two scenarios or two areas in your cardiac arrest that there are some confusion. For example, you arrive on scene and your fire department is already there doing your chest compressions. So now you and your partner, you can either do airway or you can do the pads. Which one do you assess first? Well, if you had to pick between one or the other, airway should be your priority because you're already pumping the chest and getting that blood to circulate, but that blood is being circulated because you're trying to circulate oxygen. So now if there's no oxygen and you're circulating blood, it's not doing any good for that brain, if that makes sense. Now, should you choose to put the pads first and shock, what new life-saving measures are you adding to the equation, right? You're trying to shock their heart, so that it will start to contract on its own. But fire is pumping it, so it's already contracted manually, if that makes sense. So that part is already taken care of. I feel like it's okay to hold off on that for a second and get that airway established, right? That's my take on it. Another confusing area here is when we say early defib and airway is done and you throw those pads on the patient. Now, are you going to interrupt someone near their cycle of chest compressions to check a rhythm, to analyze a rhythm, and possibly deliver a shock? It's a bit of a gamble. I'm not saying it's wrong, but I'm saying it's a bit of a gamble because when you interrupt that compression, right, all that compression was creating pressure and circulating that blood flow. So when you ease up off that, it stopped, and you got to try to establish that again. So you're stopping that to check for a possible shockable rhythm, and if it's not, you really haven't done much good. If it is, that's great, and you deliver that early shock. That is an early defib, which has been shown to show some really good results. So that's really great if you're able to do that. However, is the trade-off worth it? Checking for a shockable rhythm, worth it when you're interrupting a compression, right? So it's recommended less interruption for compressions for the ACLS guidelines. Personally, I would suggest that we just let the cycle of CPR complete, at least get that 30 in there, and have those pads and monitor charged and ready to check and deliver shock that soon as possible. So for me, early is just ready to go within the first cycle of CPR. And that's how I feel about it. But again, it is a provider judgment, but that's just my take on it. Like, delivering the shock is just gonna make the heart beat on its own, and we're already doing that for the patient. So, like, you know what I'm saying? So studies have shown that epi may have some neurological damages or deficits on patients after ROSC using epi, right? So I guess enough epi can give a heartbeat to a rock. Like, that's the theory behind it. So is it actually doing more good than bad? Because if you do bring someone back, they have a heartbeat and a pulse, but up here they've lost too much, is that life worth it? Would they want to say yes if they could, knowing what their life outcome would be, knowing their neurological deficit? Would they want to come back? That is the argument. So for that, we're going to go out in the field. We're going to do some interviews. We're going to check with some professionals out there in the field and ask them what do they believe is the priority when it comes to cardiac arrest, and also what are their thoughts about epi. Like, what gives that patient the best chance to survive return of spontaneous circulation?
Yeah, early defibrillation.
Early defib?
Yep, absolutely. And then some good solid chest compressions.
All right, yeah. There it is. Early defib and good solid chest compressions. All right.
That's what you can do.
Thank you, Steve.
Yeah.
I know. Rapid defib and quick CPR.
All right. And how do you feel about epinephrine? Good or bad?
I would say it's good.
It's good?
Yeah.
All right, that's another one for Team Good.
Yeah, I would say there's like evidence on both sides to indicate that it's good and bad depending upon what point of view you're taking with it, because initially everything gets back faster, but long-term post-ROSC you have more concerns with it. But
there you have it, an expert in the EMS field. It says it is good, Team Good. Early defib and good quality compression, right?
That's right.
What do you think is the most important thing in cardiac arrest?
The most important thing in cardiac arrest, you mean management?
For the patient's survival.
The patient's
higher
survival.
chance that that patient would survive. What is the most important thing?
Quick intervention, proper intervention. Mm-hmm. So compressions being started early, defib being started early, as well as ALS providers being able to recognize and correct H's and T's.
And what do you think about epi?
Epinephrine.
That is a controversy. Is it good? Is it bad? How do you feel about it?
I think that enough epi can revive a rock, and I think it will be phased out eventually.
During CPR, what do you find is the most important thing that would increase the patient's chance of survival?
According to the American Heart Association,
here we go.
That would be chest compression fraction. Basically, like, maximize the amount of time that CPR is being done, high quality CPR. Minimize interruptions to less than 10 seconds.
All right, now the vote. Are you team good or team bad when it comes to epi?
So, I think that the evidence suggests it's more harmful in the long term. I value quality of life over quantity of life. And I think if we're not getting people back with good quality of life, we shouldn't be getting them back at all.
Early recognition, good quality CPR with minimal breaks and compressions, and early defibrillation.
All right. And regarding epi being good or bad, what is your thoughts?
I think it's bad. It has proven to be not as, or just as efficient as getting Roscoe's not using it, but we also are looking at good neurologic outcomes, and it is proven to have worse neurologic outcomes than not using it.
Early chest compressions.
Early chest compressions?
Oh yeah.
That's it? All right, solid.
And defibrillation,
And
depending
defib.
on what the rhythm is.
With your top priority, you say?
Chest compressions.
Love that. Do you think epi is good or bad? How do you feel about it?
I think it's useful.
That's it?
Yeah.
There you have it from an EMS professional out there in the field. Cardiac arrest, she says, early compressions. And epi is useful.
And amio.
That's like, I'll give you one for yes, one for good, one for bad. That's like in the middle.
Yeah.
All right, so team neutral. All right, 10-4.
What do you need, Lee?
When it comes to CPR, what do you find to be the most important thing that would increase the patient chance of survival? Most
High
important
quality, effective, depth.
Okay, but they were originally
Depth.
Depth and rate.
Depth and rate. What's that rate?
100 to 120.
All right. And are you team good or team bad when it comes to epi? What do you feel about
Team
epi?
bad.
high quality chest compressions and early defibrillation, hands down.
There it is, hands down. And then there's been a small controversy versus epi. Is it good or bad? I had one person says good. I had two people say good, two people say bad, and then one that was kind of neutral. How do you feel about epinephrine?
I think it's essential. I don't have anything against it. I haven't seen anything better come along, so I think it's gives us a good college try.
Well, thank you so much for making it to the end of this video. Those were the words and comments from the professionals out there in the field, and I greatly appreciated them. Those comments and videos were recorded with consent, by the way. So at the end of the day, you've done all the things, and the patient either lives or they die. Now, it is a sad fact, but it's something that you need to be prepared for, that you will do everything that you know to do, and you just go beyond the ACLS where you're doing it at a high quality. You're doing it at a high quality. You're making sure that you have good form. You're having great equal chest rise and fall. You're making sure you're getting all your preloads, so when you do your chest compressions, you're making sure the chest comes back to the neutral aligned position. You're doing all the things, you're doing all the shocks, you're doing all the rhythm checks, you're doing all the medication. You do everything at the top of your game with great speed and great timing, and the patient will have a really, really high chance higher than normal to survive. But at the end of the day, they just might not. And so be mentally prepared for that. It can be taxing on the brain. And I know that the mental health awareness is something that is very strong now in the EMS career field. We take that really seriously. So there are usually things set in place, people that you can talk to, resources that you can reach out to. So just talk about it. You know, even your peers, your coworkers, supervisors, and them. Talk about it. So you're not alone out there. Just remember, you've done everything you can, and sometimes you just gotta move forward. Right? My name is Leaton Mitchell. Again, thanks for checking out the video, and stay safe out there.